Hello there, I'm Stephen Bunting and I'm an MSK physiotherapist working in the northwest of England. If you're new to the channel and want to know a bit more about me and why I'm making these videos, then I'll put a link up here, or you can see the video description below. This video is all about De-Quervain's Tenosynovitis, also known as De-Quervain syndrome, or just simply De-Quervain's, and also its sister condition, intersection syndrome. Before we get started though, please note that this video is for information only and is intended for people who've already been diagnosed with the condition by a healthcare professional. So if you think you may have it but haven't been diagnosed, please get checked out professionally first. Okay, so with that done, let's get started with De-Quervain's Tenosynovitis. As with all my other MSK videos, I'll be tackling the condition by answering the 3 most common questions asked by patients, and I've put timestamps to the relevant sections if you want to skip around. So question 1, what is it? And within that, we'll discuss the typical symptoms. Question 2, why have I got it? And question 3, what can I do about it? What are the treatment options? Okay, so on to question 1, what is De-Quervain's Tenosynovitis? Well, the condition is named after a Swiss surgeon who first described it in 1895. That's the De-Quervain's bit. The Tenosynovitis bit, like many medical terms, is derived from the ancient Greek and means inflammation of a tendon sheath. The tendons involved in De-Quervain's are located on the thumb side of the wrist, just here. There are 2 of them, and they run side by side along the thumb, across the wrist and then into the forearm. The 2 tendons are called abductor pollicis longus and extensor pollicis brevis, but we shorten them to APL and EPB. They pass under a fibrous tunnel as they cross the wrist, and it's at this point where they can become irritated and inflamed. The condition is essentially an overuse injury which causes friction and swelling to these tendons. The main area of tenderness is usually just here, around a bony area of the wrist called the radial styloid. If you slide your finger off this bone towards your thumb and then lift your thumb up as if hitching for a lift, you should be able to feel the tendons tighten up, and this is usually the point of maximum tenderness in most cases. Sometimes the pain may be a little further into the forearm at another area of potential friction, this time where our 2 tendons cross over a neighbouring set of tendons lying underneath. This is actually a slightly different condition called intersection syndrome, but we treat it the same way as De-Quervain's, so for the purpose of this video we can bundle the 2 conditions together. So that's De-Quervain's Tenosynovitis and indeed intersection syndrome in a nutshell. Now let's move on to question 2. Why have I got it? Well, the condition is essentially an overuse injury of the wrist, which aggravates the APL and EPB tendons. The type of activities that typically cause the condition can be heavy lifting or strenuous activities, for example gardening or heavy manual work, or perhaps a sudden wrist sprain due to an injury. But more typically it's caused by low-level repetitive activities over many weeks or months. Things like gaming, crafting, playing golf or racket sports. But by far the most common group of people that we see with the condition are new mums. Picking up babies and toddlers frequently can overload these wrist tendons and cause the condition. Indeed, it's also known as mom syndrome in the USA. And the particular movement that causes it is this up and down movement of the wrists, the karate chop action, which we call radial and ulnar deviation. And if this action is done repetitively, especially whilst lifting a weight, well, that's the recipe for developing the condition. And this is exactly the activity that parents of young children do time and time again. So now we know what De-Quervain syndrome is and also what causes it. Now let's discuss what we can do to get it better. Well, because this is an overuse condition, the first and most important thing you must do is reduce the activity that is causing the problem. Otherwise, you'll be fighting a losing battle. If you can't stop the activity completely, which may well be the case if your job is the cause, or indeed picking up your children, then at least try to reduce the activity as much as possible. If it's an occupational overuse problem, then talk to your employer about the option of lighter duties for a while, or making some workplace adjustments to reduce your wrist strain. Wearing a wrist splint can also be really helpful in reducing the stress through the tendons and is the main self-help treatment that you can try. I often see people using thumb splints for De-Quervains, but they don't tend to work so well because this isn't a thumb condition, it's a wrist condition, as the overuse movement that causes it is that up and down karate chop movement of the wrist. So the right type of splint should be one that supports the wrist and limits wrist movement. Something like this, which has a metal support bar sewn in, should be effective. You can also get splints which support both the wrist and the thumb, such as this, which will be really effective, but you might struggle to do much with your hand whilst wearing it, as it works a bit like a plaster cast. The best splint for you will depend on what you still need to do with your hand whilst wearing it, and unless you can fully rest your hand whilst at work or home for long periods of time, then the wrist splint will be the best option. Try to use the splint as much as possible when active during the day. Unless it's very painful at night, then you don't usually need to use it in bed. I'll put a link to these splints in the video description below. Another good self-help treatment is the use of anti-inflammatories. Because this is a condition of tendon sheath inflammation, an anti-inflammatory drug can often be really helpful. Please talk to a prescriber or a pharmacist first though, as not everyone can take anti-inflammatories. A course of tablets such as ibuprofen taken over a few weeks can be helpful, but using the gel is often just as effective and has less side effects. Because these tendons are so close to the skin surface, an anti-inflammatory gel can penetrate to the right depth and effectively treat the tendon sheath inflammation. It's usually best applied around 4 times daily, but read the packet to see what the optimal dose is for the type of gel you have. So to summarise, stopping or reducing the aggravating activity and then using a wrist splint alongside anti-inflammatory gel over a 6-week period can often help settle down the majority of cases of De-Quervains. For the stubborn cases that don't improve, then the usual next step in treatment is a cortisone injection. A small dose of cortisone injected into the tendon sheath has a 70 to 80% success rate in curing the problem and can often start working within a few days. The injection can be repeated if it doesn't get the problem fully better first time round. And finally, if the problem still persists despite trying all the things we have discussed so far, then you may need to talk to a hand surgeon about the option of surgery. This is usually considered a last resort option for this condition. As with all surgery, there are potential risks, and with this particular operation, there is a risk of irritating a nearby nerve, which can cause prolonged pain and discomfort in some people. The procedure involves cutting the roof of the fibrous tunnel that the tendons pass through as they cross the wrist. This gives the tendons more breathing space and allows the condition to settle down. The tunnel will heal itself again within a few weeks, but it generally heals in a wider position with less tension on the tendons, and so hopefully the condition doesn't come back again. The surgery for intersection syndrome is also considered a last resort option and involves trying to remove the swollen and inflamed tendon sheaths at the point where they rub against each other. Both procedures are often done under local anaesthetic and involve a large bandage for about 10 days until the stitches come out, and then a splint for a few more weeks. It can take up to 3 months before everything has settled down fully. And that's it. I do hope you found the video helpful, particularly in showing you how to settle the condition down yourself. And we've discussed some of the other treatment options available if the problem still persists despite your best efforts. Please feel free to leave any comments below, but please be aware that I can't provide any personal advice. Thanks very much for watching, and bye for now.